Welcome, and thank you for joining the final webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing series. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. It is now my pleasure to introduce our moderator for today, Professor of the Practice at the Johns Hopkins Bloomberg School of Public Health and Director of the Hopkins Center for Humanitarian Health, Paul Spiegel.
Good morning, good evening, good afternoon, wherever you may be. It's a pleasure to have you join us for our final webinar. This will be the final of actually 14 webinars we've done on COVID-19 and humanitarian health. And I'd love to say after this, we've all learned and we know what is happening with COVID and humanitarian, but there still remains so many questions. What we're planning to do today is we have six five wonderful speakers, apologies, who are going to talk about some of the lessons learned. What we did is we have 3 universities, the London School, the Geneva Center for Humanitarian Studies, which was previously called SARA, and then the Johns Hopkins Center for Humanitarian Health. And we have, early on, we put together a website where people can see guidelines in various forms and also upload field experiences. And so for our last webinar, we thought we would share, talk about the website, but also more importantly, talk about some of the lessons learned, specifically triage and sexual and gender-based violence. So without further ado, I'm going to introduce Alex Odlum, who is a research coordinator at the Geneva Center for Humanitarian Studies, where he works on COVID-19, the COVID-19 Humanitarian Platform, and the Humanitarian Encyclopedia project, which is a collaborative online platform to co-produce and apply knowledge to guide future humanitarian response. Alex will present the website and some of the key findings behind it. So Alex, over to you, and thank you.
Thanks, Paul. Thanks very much for the introduction and for all the webinars so far as well, to everyone involved. It's been really good. I'm just sharing my screen quickly, and I'll get started. So hopefully everyone can see that okay. And so yeah, thanks so much for having me. So yeah, I've been working with the other institutions on this really insightful and interesting project to set up a COVID-19 humanitarian platform. And today we're going to talk about some of the lessons learned, and I'll focus on the sort of process of how we've come up with some of those lessons. So I guess the first thing to touch on is why we got interested in collecting lessons learned from field environments in humanitarian settings. And I think one of the initial reasons early in the pandemic was that as the virus spread, around China and Europe and some of these northern contexts, the responses weren't necessarily feasible in humanitarian settings. So we needed to explore what could be feasible in those settings. A second issue is that there's a lot of global guidance, and we've collected some of that, and as have other initiatives, but it still at the local level needs some kind of adaptation to context. And then finally, I think it was a good opportunity to promote learning in real time and to try and share these experiences so that they could be acted upon in real time. So how we did it, we facilitated sharing through the online platform, and I'll go through a little bit what that looks like. We gathered and curated and analyzed and interpreted field experiences from different partners and humanitarian organizations and individuals, and then disseminated them back through the platform so that they could be used. And we've started to compare, how the experiences relate to the guidelines, and that'll be a little bit the focus of the speakers later in the session. And then finally, we're getting to a stage where, as Paul said, there's many questions unanswered, but there's some that we're getting closer to being able to answer. And so a new feature of the website, as it stands today, is to look at some of the technical questions and try and provide answers. So you can see here on the slide a little bit how the platform is structured around a framework. And there's three main categories to the framework. You can see at the top there. So the first one is about preparing for and responding to COVID-19. And so this is all about specific interventions that have been designed or rolled out in order to tackle COVID-19 and some of the risks and issues it presents in humanitarian settings. So this ranges from case management to surveillance systems and investigation through to risk communication and community engagement to prevent some of the impacts of COVID-19. The second area is about adapting existing interventions. So we've looked at how ongoing health services and other humanitarian services have been adapted to be able to function or deliver, essential kind of provisions and support whilst handling some of the issues of lockdown and navigating the risks of transmission and trying to mitigate them. And then finally, there's cross-cutting issues that we've looked at as well, which are essential to both adaptations and specific interventions, from coordination through to gender and protection issues. And we'll also take a look in a bit more depth at specifically at sexual and gender-based violence later in the webinar. So on terms of how we collected these field experiences, there was two main pathways. So through our platform, we created a possibility for organizations and individuals to submit online how they were, their experiences and to describe in a little bit of detail what they've been doing to adapt or intervene in COVID settings. And then we follow up with them to explore the details and to really flesh out what was unique in that context. And then secondly, we've also reached out through our networks of contacts to do short interviews, sort of 20, 30-minute interviews to also, get the details on how specific interventions have been adapted. And we write these up into summaries and we've disseminated them on the platform and through our social media networks. And the idea is to look into the rationale. So why was this intervention done given the context-specific details? Look at the process step by step, really kind of go into the details of the modalities and the resources required. And then finally, to look at some of the challenges that made it difficult to adapt in this way and the enabling factors that maybe we could try to replicate in other settings. So to date, we have finished 63 interviews and then we finalized those into summary field experiences in 31 cases. And you can see on the map there a sort of example of how these are spread across a wide variety of locations and humanitarian settings. And as a user of the platform, you can come on and if you're interested in a specific region or country, you can navigate that. But also if you're interested in a target population, for example, displaced, you can navigate that. Urban, rural settings, or specific areas of the framework just presented. And in terms of coverage of that framework, we've been able to have interviews and write summaries for a good proportion of all the different areas, some more than others. And so it's been quite interesting just to look at the distribution of how our networks and how our interview data collection process has evolved. And we see that triage is something that's come up from many organizations we've spoken to, as well as infection prevention and control. And it seems quite, like a common approach to somehow separate non-suspected and suspected cases or non-COVID and COVID cases in a variety of health facilities and other facilities. But also, there've been a lot of movement towards doing distributions away from centralized congregations and more, through remote modalities, whether it's delivering door to door or implementing cash or card kind of voucher systems. Communication has almost been universally referred to, community engagement and community awareness about the risks of COVID and how to seek help and assistance in this context. And then data collection has often moved online. And then what was interesting, we didn't get so much so far on severe cases, and this might be a feature of humanitarian organizations that we speak to tend to refer to other bigger health facilities, and we still need to learn how those facilities are operating. As well as some of the cross-cutting issues. It's pretty stark to see WASH, diversity and gender without any specific experiences, but we can definitely see that these have been incorporated into a large number of the above interventions that we've discussed, and it's frequently mentioned in the interviews. So just a final point here before I finish up. The coverage in terms of geographic areas is quite good in some regions. So we've had a lot of experiences from South Asia and quite a few there from the Middle East and East Africa, North Africa as well. But definitely there's a few hotspots that we are missing and would love to get more information on. So Yemen, Venezuela, and some of the Sahel belt. So if you're out there and you've got an interesting adaptation that you would like to sort of share with other humanitarian practitioners, please visit the site, and we'd love to sort of work with you to turn that into a summary. So thanks. That's the sort of overview, and I'll pass back to Paul.
Great, thank you very much, Alex. Please remember to put in any questions or comments you have into the chat box, and we will try to answer them at the end. So it's my pleasure next to introduce Neha Singh, who's the co-director of the Health and Humanitarian Crises Centre and assistant professor at the London School of Hygiene and Tropical Medicine. She's a health policy and systems researcher with a focus on improving health service organization and delivery for women, children, and adolescents in humanitarian settings. Neha will speak for approximately 7 minutes or so, and then we're going to move directly to Hrida Anani, who is the founder and director of Abad Resource Center for Gender Equality in Lebanon. She's also an assistant professor in the Faculty of Public Health at the Lebanese University, and she leads a dynamic team comprising more than 140 female and male human activists, lawyers, consultants, social workers, and researchers dedicated towards achieving gender equality and women's empowerment. So thanks again, and Neha has been instrumental in the website, so we really appreciate all of her work. Over to you, Neha.
Thank you, Paul, and thank you so much to everyone for joining. I think you see my screen. So I'll just, I think as Alex and Paul were just saying, I'm just going to share our experiences from collecting, from speaking to humanitarian actors about sexual and gender-based violence. I'm going to call it SGBV going forward. And just to say that I mean, it's a very brief presentation, but I just want to provide a rationale, talk about the similarities across these field experiences, the differences, and then also emerging lessons for programming. So SGBV, in especially in the times of COVID-19, there's alarming information on increased SGBV occurring against the backdrop of the outbreak. And we know that many of the measures deemed necessary to control the spread of the virus are not only increasing SGBV-related risks and violence against women and girls, but also limiting survivors' ability to distance themselves from their abusers, as well as reducing their ability to access external support. It's clear from several previous epidemics that during health crises, women and girls typically take on additional physical, psychological, and time burdens as caregivers. So it's critical that all actors involved in efforts to respond to COVID-19 across all sectors take SGBV into account within their program planning, but also implementation. So this will look a bit familiar because Alex just showed you what our field experience page looks like. But today I'm going to be reporting sort of synthesizing findings across field experiences from Lebanon and Haiti. So what are the similarities across these field experiences? Not, unsurprisingly, strong community mobilization and support. Often this was there prior to the pandemic, but this becomes particularly important when working in these challenging times. All the NGOs we spoke to were in a very unique position and a very they were happy to have adequate and sustained funding to be able to mobilize their programming the way they needed to. And also, I mean, even though this has been used prior to the pandemic, the use of and the creative uses of media and digital technology. So using WhatsApp, for example, to reach target populations, both for calls, but also to deliver content. And also, for example, in Lebanon, one NGO is using it to actually provide counseling and doing group counseling sessions, individual counseling sessions, so forth. Also using WhatsApp groups to support implementers, social media, local radio, hotlines, and also, in Lebanon, there's an NGO that's encouraging influencers to subtly spell out hotline numbers during videos on cooking and other topics that are unrelated to domestic abuse. So again, kind of getting creative in how you get these messages out there and reach the people that you're trying to, your target population. Unsurprisingly, partnerships and coordination to enable dissemination of messages is also key and are common to all field experiences we've collected on this topic. And mainstreaming SGBV into other programs. So for example, putting a hotline number on the back of a World Food Program card for cash distributions in Haiti. I think none of this will be none of this is particularly unique to COVID-19 or programming during COVID-19, but the way that NGOs are getting creative with trying to solve problems and adapt, I think this is sort of common to across sort of both settings. So what are the differences we're seeing between field experiences? So depending on the NGO, their resources and sort of their focus, the target populations are different. So some NGOs are only focusing on women, because they're having to prioritize resources. And for example, Abad in Lebanon, and we're going to hear from Rida just shortly after me, are reaching everyone. They're targeting both men and women. And then who delivers the intervention? So fully women-led or not? Again, it's context dependent. An NGO we spoke to in Haiti, they chose to use female community mobilizers and only women because they're reaching women, and that was only women, that was appropriate. Other NGOs we've spoken to have used, both male and females. Again, in Lebanon, we see, in addition to these sort of frontline workers, the use, getting creative with the use of influencers, so social media influencers, people who are delivering sort of cooking shows and so forth. And then there's the modalities of implementation. And again, this is so context specific, of course. So we should be seeing differences here. So for example, in an NGO that's working in more rural, remote areas in Haiti, for them going mainly remote, sort of using phones just wasn't feasible for the populations they work with. So they continued most of their programming in person while following social distancing rules and obeying the laws around restrictions and so forth. So they continued using friendly spaces and using community mobilizers, but they were in full PPE, using megaphones, so forth. And then in Lebanon, one NGO we spoke to, they actually pivoted their programming to being mostly remote, except for with high-risk populations. So when they were going mostly remote, they developed an e-awareness platform, and we're delivering psychosocial support and emotional support sessions remotely, so over WhatsApp mainly. So what are these emerging lessons for programming? Being adaptable to evolving situations. So as the societies come in and out of lockdown restrictions, for example, being adaptable to including additional groups that may come to you seeking care and advice. For example, an NGO we spoke to in Lebanon said that in their hotline, they started getting a lot more calls and sort of engagement from men who are finding the current climate really challenging economically, and they're feeling angry and stressed and so forth. So they pivoted their programming to be able to work with them and provide support to them as well. Addressing literacy challenges. So in addition to written materials, being able to deliver audio messages at scale when you're not able to talk in person to people or do so many individual phone calls. Related to that, kind of challenging assumptions. So an NGO in Lebanon had traditionally been reluctant to hold online activities before the pandemic for fear that participants, especially Syrian refugees, would find it more difficult to engage, but they were actually surprised because this population has been very engaged with the NGO's activities. The online format seemed to give participants a certain degree of freedom as they were asking more questions and reporting less fear of judgment. And then I think especially this is for all programming, but especially for SGBV, mitigating risk and adopting a do no harm approach, especially in these times. So this need to adapt protocols, but also to introduce new protocols to not put people at higher risk. Some adaptations reported by various NGOs include using an agreed upon word in a phone call in case a woman or your participant faces immediate threat that they're not able to talk about, deleting message history and not saving contact details. This is particularly important when mobile phones are often shared. Providing data packages so that women or participants can access internet on their phones, or even just be able to make a regular phone call. And then this, I think data protection and privacy and storage is really key at any time, but particularly when we're using we're relying on these technologies so much more. So for example, an NGO in Lebanon got around this by investing in secure cloud storage.
If you can finish up, Neha, because of time.
Yes, and then I just have two. So just the final two lessons, supporting frontline workers, so not losing sight of that. And then also recognizing that these are challenging times, but it's also an opportunity to work multi-sectorally, to strengthen existing systems instead of creating parallel ones. And I will stop there. I think as if you have any questions, here's my email. Alex said, you can share your experience via a form on our website, or just email us, and we're happy to set up a short interview if you prefer. And if you'd like technical advice, please use the new form on our website. Thank you. And now I'll hand over to Rita.
Rita, over to you.
Thank you, Paul. Thank you, Neha. Good morning, everyone. So allow me first to share with everyone a hands-on experience, recent experience that we did in Lebanon, a campaign called Lockdown, Not Lock Up, which is a very practical campaign that we used as a tactic to promote the helpline number to survivors, to be able to reach out to survivors. So first, I would like to share with you a very short video that can explain what we did and how, and then we can have share some practical learning from that campaign and service delivery in Lebanon.
Abused by her husband and her father-in-law.
غسيل الأبيض الخميس.
Push-ups, minute of planks, 7 squats and 8 jumping jacks.
88
Thank you. So basically, and reading as well some of the questions already shared, it's important to note that first, it was a great tool in sense of making sure that women in communities are aware that, yes, it is a lockdown, but it's not an interruption of the service. We had a real increase in the number of calls, which not by necessity we can say that yes, it's there's an increase in domestic violence, but at least the women are more aware about the existence of service, the number, and the solidarity among people was very important in contexts like Lebanon and the Middle East, where like breaking the taboo around gender-based violence, and then the issue of victimization and even double victimization is very associated to the topic. So but it is also important to note that the technology, ICT technology, was also one of the medium used by women, namely in Instagram, the messenger of Instagram, because when woman is at home and with the perpetrator around her, it's very sometimes difficult to actually make a phone call per se, fearing that he's gonna be hearing her or like it might be increasing the risk. So women were using the messenger of Instagram, being usually a platform where you scroll down and you have pictures, so it's safe if he's around, even if she's talking and chatting. Also in the messenger of Facebook, meaning that we had to also train our team on skills related to like case management or e-counseling per se. We produced some guidelines, adapted some of the guidelines we had on remote case management that we made also available and provided immediate refresher training to our team, which is a team of, we have a team of 140 full-time staff located across the country to be able to provide helpline counseling, but also face-to-face in high-risk cases, but also taking into account the protection and the safety measures related to COVID. So also some of the adapted guidelines had to be produced specifically on how to do face-to-face case management while wearing a mask, while we know that the human contact is very important. And wearing a mask and having the survivor wearing the mask, and especially in high-risk cases, it might have some implications on the quality of the trust relationship. So we had to produce some community-friendly also material to explain about the concept of mask while providing the service and why it's important for her own safety additionally. And we had to adapt some of the protocols related to e-case management and e-counseling and e-support group that we had to integrate within that as well. Mental health, we had to integrate some of the mental health tips, some of the mitigation tips, some of the safety and security related information, but most importantly, the data safety protocol. In Lebanon, as many would be aware, we're an open system country, and everything is almost like kind of also controlled, especially the communication arena. So doing like a kind of counseling through the platforms like Messenger on Facebook, sharing some, I don't know, pictures, documents, was highly risky if it's not properly managed. And also caseworkers on helplines responding across the country from their homes, also documenting information related to survivors. That was a big question in our context, like how we do data management in a way where we ensure confidentiality, privacy, but also a continuity. So these are not lost, so they are properly stored.
Rita, if you can finish off shortly, and there'll be time for questions.
Yeah, sure. So one of the quick ideas that we had to shift to is using the secured clouds, where and create a kind of mobile application that linked all caseworkers together, where they can document the like call logs for helpline, but also they are connected and monitoring the trend if they wanna upload the data related to the survivors on the secured cloud. The guidelines that I mentioned are also available on our website under the resources section, that you can find even like some of the guidelines related to chatting and texting related to the context. And I'm happy to to answer any additional practical questions once we have a round of question and answers. Thank you so much.
Thank you, Rita. That was really, really interesting, and the work's incredibly impressive. I remember reading the field experience before we put it up.
Yeah.
So please remember that I'm already seeing some questions, but please remember to ask some questions on this particular topic. And we're going to move to the next two speakers. Kiara Altara works at the Center for Humanitarian Health, and she focuses on measurement methods for complex settings, infectious disease, M&E and outbreak responses, and health service provision in conflict-affected settings. Kiara will be talking about triage, and then she will be followed by Marie Petri, who's worked in DRC since 2019, first managing IPC programs in North Kivu for MEDAIR with the Ebola response, and then is head of the Health and Nutrition Department of ACF, covering both Kinshasa and Eastern Congo, and emergency responses in all the provinces. So thank you very much. Kiara, over to you.
Thank you so much, Paul. I hope you can all hear me well. Good morning, good afternoon, everybody. I'm going to briefly share my screen. And I'm lost already. Tick. Here. Sorry. Mentioned indeed in the second part of the webinar, we're going to talk about triage, given the importance of this step in managing and so in identifying and managing COVID cases and separating them from other uninfected people to avoid the spread of the disease. As Alex introduced, we are going to summarize a couple of experiences that we received and that were shared on the website, as well as other discussions we had with actors currently involved in the response. And I'm going to follow a similar structures as Neha's presentation, trying to highlight first some similarities, and then focusing more on differences in some sort of operational challenges, operational implications that came up and that require further thoughts, probably discussion and investigation to see how actually would be better set up and better developed to improve the response. So again, this is the map that you will see on the website, and specifically for triage, we had experiences from South Sudan, Somalia, Myanmar, and Greece. And I'm going now to focus on this and highlight a couple, again, as I said, a couple of similarities. First of all, we found that everywhere temperature was used as the first and main screening criteria at the entrance from health facilities, which is per se probably not surprising given the case definition and the characteristic and the symptoms of COVID. But as you will see in the differences, other symptoms have been used differently across the triage. So at least this is a commonality in all countries. So the first thing that is done is indeed the measurement of the temperature. In all countries, there is a national protocol that has been adapted from WHO guidance, and it includes the all key components of an outbreak response with a case definition, and then the triage and the circuit of the patients, as well as other community-based or so response and so case management activities. Everywhere we could see that COVID-specific facilities have been set up, either literally new facilities or repurposing, for example, previous facilities used for more broadly infectious disease treatment, or simply separating using a sector, a floor, or a ward of a hospital, of a health, already existing health facilities, specifically for COVID. Indeed, all experiences that we had were of NGOs working with and referring patients to governmental facilities. So per se, COVID-19 facilities are run across countries by the government. Similarities, we found similarities also in terms of challenges, mainly, again, across the board, difficulties in procuring personal protective equipment, both for the reduced capacity to import material, at least initially with the reduction in global transport. And then, of course, it took time to find regional, national or regional solutions that then were able to provide necessary PPE. And similarly for testing capacities. So everywhere, testing capacities is available in the capital, but it becomes much more challenging once we leave the capital indeed. Even though, again, according to the country, we could see new laboratories being set up or at least announced, and then in some having already a more decentralized approach. And finally, almost all experiences discussed human resources availabilities, some literally noticing already a lack of sufficient human resources, and some others more forecasting needs for human resources should a spike in cases occur, like we have seen in many other settings. Given how each country and each setting, given how specific each setting is, probably we saw more differences than similarities. And here, as I mentioned before, so we did see different ways or different moments in which specific symptoms or specific components of the case definition was used across the triage process. So for example, respiratory symptoms and the epidemiological risk. So whether the person has traveled from in an area with cases or was in contact with cases have been asked in different moments. Then we did see differences in terms of investigation. So where the investigation takes place. So either at the alert point, so where the patient is, or whether the patient has to go to the COVID facility and be investigated, and whether the investigation team is an external team which is roving and going to the case, or it is embedded in the health facilities. Another interesting differences was how, again, embedded or explicit in the triage system is the identification of other diseases. As we know, the symptoms of COVID are pretty unspecific, and so it is important to rule out as soon as possible whether it is rather malaria or measles or other fever or other diseases showing fever. And this was done differently across countries. So while this was certainly one of the common steps that were discussed, only in one country it was explicitly integrated in the triage. Then hotline everywhere, and it's also something recommended so it was recommended for Ebola, and it is recommended by global guidance to have a hotline to both provide information, but also for the population to provide alerts. And this indeed was used differently in the different countries. So sometimes was available for the population, and sometimes was used by health facilities to call the investigation team. We also saw some differences in the way the referral is defined. So if it's compulsory, so in a couple of countries, patients that are that show fever and respiratory symptoms, so that fit the suspect case definition, are obliged to go to the COVID facilities. In others, it's more on a voluntary basis. And here we see also according to clearly according to the setting and the relation with the government and so especially if it's a conflict affected areas or not, we could see different perceptions in acceptance of the approach. And then finally, the fact that in certain countries, next to the triage at the health facilities, there was a community-based component in which community health workers tried to reduce the number of consultations going to the health facilities.
If you can just finish up, Kiara.
These are the four issues that basically remain to be clarified. These are sort of unanswered questions that could benefit from future attempts and future investigations, literally to see whether the fact that, for example, in terms of case definition, whether asking fever and respiratory symptoms or fever or respiratory symptoms facilitate the identification of more confirmed cases, how to make the investigation most efficient, so where to have it and by whom. And finally, the issue of consultations not related to COVID and how to ensure that health services are provided despite COVID, and then overall trust in government. So, and how we can provide a service in conflict affected areas, ensure that people do believe it is for containing the spread. That's it. Thank you very much all. Looking forward to the discussion.
Thank you. And over to Marie.
Hello. I will speak about the COVID in DRC, and we can make the link with the challenge I just presented. In DRC, also when COVID started, we still had the 10th Ebola epidemic running, and it's why in one way we could see, okay, there is some experience to respond in epidemia to put triage isolation in place. But in another way, if we want to learn from what's happened in the East, is why the response team of Ebola were attacked, the triage were burned, the isolation were burnt, or the people who completely avoid the health facility with this triage and this to go in the tradition healer. Is why it was, okay, how can we adapt and put a program who can provide an access in the health facility to the patient? Because what we could see also during Ebola, it was very decrease of patients in health facilities, while less access to the health facility, even for pregnant women giving birth outside of health facility or other things. That's why it was very objective to increase the access of health facility, because we could already see then see also perception of the people than the health healers and yes, the population, the patient decrease at health facility when COVID started. And also the main challenge was we are doing in Kinshasa, in the capital, where it's quite different in the countryside. First, also for the building, because we had some building who just give on the street. This is why we cannot say, okay, we have a big compound and we can build a nice installation. And also there is a 80-90% of the health facility are private. This is why how can we introduce this and how can we see the perception. So first we discuss with the health facility, we're quite welcome for this. But after we see which kind of, okay, we train the people of triage, but also which kind of installation we can put and can be accepted by the population. It's why now we look a little bit and we take not at all the same than in the East. It's why not a plastic sheet or things like this, but more like a tent that the people use in the streets, a small in small market like that. It can have a better acceptance for this, and now to see the perception, because also we had some analysis done by a group of social group who bring back that the population may be happy to have more triage and IPC in the health facility because they will feel more protected. But just now that we started the triage, in one way, in some places it's accepted, but in some other place there is very reaction from the population. It's why, yes, I accept this, but if it's them, we put them at the triage, at the isolation, the time the investigation team come, they don't accept this. It start to say, yes, but here we don't have a COVID. If you say that, it's why you say there is COVID in our part of town. It's why now it's all the time continue to have the perception of the people and to have the capacity to adapt the response. Also, what quite surprising, it's for example, for the thermoflash, they say, no, but now it's a detector of COVID. Why do you put a detector of COVID in a health facility? It's why every day we need to follow what is coming back from the health facility and from the community to see and to adapt this. And also one of the other challenge, it's also because now we do more triage, we have to call more the investigation team. And when we call the investigation team, now they are more busy and they have less and less capacity to answer quickly or to come, or even sometimes they don't come at all at the health facility. And it's why after how we can see, we can act with a patient, they will kind of escape or to go back home because they don't want to wait so long and they don't want to have a big flag on them. And also, if I can make the difference, the link with what was said before is also, yes, if you look the definition of the case for COVID, for example, here we are working in 3 active zones. It means that already, if we can say, yes, the patients are from active zone. It's why if you take the decision, if you have just a fever or coughing, you can already be in isolation room. And now it's a dry season. It's why many of the people who come at the health facility, it's or they are fever or they are coughing or some respiratory infection. This way, it's very important that we want to follow all the data from the people who are at the triage, the time it takes to be investigated, to be tested, to be and to have the result, and to see also if after the all morbidity data, if the people increase or decrease for the frequency at the health facility, and to adapt, I will say, on a weekly basis.
Thanks, Marie. If you can conclude shortly, and then we'll go to questions.
Mm-hmm. Yeah, no, I think that's all. This why where we are today on the implementation of the program.
Great. Thank you very much, Marie. If the presenters can all put on their videos, we have about 12 minutes left. And I want to start actually with Frida, if you can put on your video as well. I want to start with some of the questions that have come up on SGBV, and specifically then obviously to Neha and to Frida. How are you able to, number one, differentiate? There's an increase compared to previous. And then number two would be how to ensure, you talked about this a little bit, but when people are in the, let's say a woman is in the same house as the person that is committing the violence, what are different ways to be able to make sure that they can speak openly and that you're not actually making things worse?
I think if it's okay, I'll take the first one to start, and then I think I leave the floor to Rita to speak about practically. But I think Caroline Favas had a question also about the evidence base. I think there's two things here. One, there's been no rigorously conducted study during the time of COVID to say, okay, this is the increase in risk. But there are reports from high-income countries, low-income countries, middle-income countries recording the increases. And we know this because basically many hotlines are overwhelmed. I think in the case of Abad, I'll let Rita sort of describe that, but the NGO we spoke to in Haiti were saying that they compared the usage of their services from the first 3 months of 2020 compared to 2019, and it was something like a 65% increase. And you see reports of this here in the UK and sort of all over the world. So I think, yeah, we don't have sort of rigorously collected data on this, but I think the second half of my answer is also that a lot of people who work on SGBV, a lot of the guidance documents are saying that you need to start from the position of not questioning that it's increasing. We know this from previous epidemics. We know this in previous crises that there is an increase. So actually there is a call to not collect data on prevalence just for the sake of it, if you can't link it to policy and programming and action, because that in fact, and this will link I think to your second question, Paul, is how do you make sure you're not putting people at more risk? And maybe I'll stop there, and Rita, you should please provide your thoughts.
Well, actually, yes. What we were able to rely on is basically the comparative of the call log and numbers under our meal department comparatively between 2020 and 2019 for the similar months, but also between the 1 month, like let's say April, comparatively to March with the beginning of the lockdown. So, but we can't actually yet evidently say, is it, and actually I published an article at the National around this specific question. Can we actually say that the lockdown increased per se domestic violence, or it was one of the immediate trigger, like let's say a risk factor that made unsolved conflict in family and relationships, undiscussed and untapped on conflicts, unresolved one, explode at a time of being forced to be in the same space where we're not communicating. So at families, of course, and men that have already played this position of using violence in the relationship. It's a research question. I think it's not something yet we can say, yes, directly the lockdown increase or create domestic violence. This is a big question, but I wanted actually to answer the second part of the question.
There's some noise. Yeah, okay, looks okay. And then if you could just do that within 30 seconds so we can move to.
Yeah, sure. So when it comes to avoiding the do no harm for survivors, the entire question is about actually respecting the will of the survivors. So what we're putting out there is actually the hotline number per se. It's up to the women to actually use and report or not. So they were using it for crisis, like in situation of crisis where the intervention is simply immediate intervention with either the police or transportation to emergency safe shelter for a safe accommodation. Or in the general situation, it's not a full counseling that is done online, and it's very key, because it's simply a question of like practically safety planning, what to do to avoid escalation of the situation. And it's not about a full case management session unless she has time and space to be able to do a full session. So it's a quick saying what is the situation, knowing about the options, and then it's the survivor will and decision to choose what is the best in her own unique situation.
Great,
Yeah,
thank you very much. I'm going to ask now something on triage to Kiara and Marie, and then to Alex, probably the last word on the website. So for Kiara and Marie, what's been vexing is for I think many people is twofold. Number one, and I see some of the questions here, when you come in and you look at triage, there are, especially with the relatively generic symptoms, there are many. It can be malaria, it can be another virus unrelated to COVID, and tests are not available in many of these situations. How can we, or is it even possible to deal with that? And then the second component is relating to the policies. We've seen in numerous countries that people are taken immediately, sometimes even before the test result is there, and they're isolated. And in many of our contexts, that's people already have a distrust of authorities. So do you think that isolation in these situations is always the best way, removing people from their families, or do you think at times it may be better and even more compliant to have people isolate within their households? Maybe Kiara and then Marie.
Okay, thank you, Paul. Well, this is clearly not an easy question. It's true that what we saw was that trying to rule out other diseases as soon as possible was mentioned, but not everywhere is part of the triage. And indeed, in some cases, if there is no test, the capacity to conduct some testing, they rely on clinical symptoms. So luckily, only in one country, this triage process was presented as obligatory. And indeed, so I say luckily because it's always difficult to impose a person to go, so oblige a person to go somewhere, and the risk that this person will not comply are higher, while in many other countries, this isolation process was presented as on a voluntary basis, and people were very cooperative. So there were no reports, not many at least, or of course it takes time to explain the situation, to reduce the stigma, to clarify why this is all needed, but then people would go to be tested. I could imagine that if this process is handled as close as possible to the patient, so which is probably the closest health facilities, it's likely better than being sent to the specific COVID-19 facility, maybe on the other side of the city, or maybe some outside, I don't know, your residence. Probably it's better than home-based.
Marie, and try just within a minute or so. And there's also a question for you specifically about your relationship with the authorities in Kinshasa.
Yeah, it's true. If we look the definition, it's we could almost put in isolation most of the people who arrive at the health facility, and this is one of the challenge, because also the health staff, they don't want to be so strict because they're afraid to lose client. And this is what we want to follow, to see what it's not sure it's the best answer, but what it will be the impact and how can we do. The positive impact is that with this triage and isolation, the people take distance and take more seriously the measurement and the protection. But yeah, we are not sure on the definition. It's so vague, and we don't think it will work a long time.
Okay, thank you very much. And I'm going to give the second to last word, and then I'm just going to give thank yous at the end. But to Alex, in terms of what are the areas that you think need more discussion in the website, and also how has the outreach been going, and what can we do better?
Yeah, no, I mean, I think one area that's definitely, I pointed out earlier, but I think the transition from sort of, or the separation between management of mild cases or cases that we've seen a lot of different interventions covering, and then the more severe ones, which really require a more intensive care and better facilities and more rigorous isolation and different aspects. I think the transition between those, or how they relate to each other, is also a really important thing. And I think in general, how these sections of the framework intersect and overlap is something where we should sort of steer our research efforts going forward. So I think that's probably it. And the second part of the question was
more how can we, I know we've asked people here, but outreach, how is the what would you recommend to people in terms of, and us, but also the people here, and how to do better outreach to get more experiences?
Yeah, I mean, it's great obviously to create a bit of momentum through contacts. So if you found the discussions through the webinars useful and the website has interesting content for you, please, I mean, spread the word through your crowds and networks. It's been interesting. A few people have posted on the chat today as well, that they'd be happy to contribute. I think it was Abdulaziz from Yemen said, I noticed you have a gap from our country, so I'd be happy to sort of facilitate that. So obviously, you know, following up and building those connections will be very helpful. And I think, you know, like being transparent and displaying, you know, like on the maps we showed where we do have experiences and where we're lacking them is also helpful to get a broad coverage of countries and framework areas where we need more information.
Great, thank you very much. So this is the last webinar in this series. I want to thank everyone, particularly Reddy and OFDA USAID, Ryan Toney, who has been really instrumental in getting these moving. And for the website, beyond the people that are currently here, Kiara and Alex and Neha, thank Carolyn Favis, Orit Abrahim, and Carl Blanchet. Thank you, everyone, and please be safe during these uncertain times. Have a good day, evening, afternoon. Bye-bye.
Thank you.
Thank you all.
Thank you.